الو.
يا دكتور سامعينك دكتور أسامة.
ايوه
أهلا بيك دكتور ابتسام.
يلا
we can start.
يلا الحمد لله على السلامة يا دكتور أسامة.
اهلا
I will
دكتور
share
ابتسام.
السلايد من عندي يا دكتور.
ها
أنا هشيل السلايدز من عندي. أوكي
يلا
أوكي دكتور ابتسام we can start.
يلا نبدأ. بسم الله. بسم الله الرحمن الرحيم. Good evening, ladies and gentlemen. On behalf of Boehringer, I would like to welcome you all today, and I'm honored to moderate this session. My name is Ibtisam Baisa, consultant endocrinologist, and I have the privilege to introduce my colleague, Dr. Osama Khatib. Dr. Osama is a senior endocrinologist at Al-Mania Hospital, and he is a fellow at the Imperial College of London. He had his graduate medical from Hammersmith Hospital, University of London. Without any delay, I will open the floor for Dr. Osama to talk today about his topic will be about beyond hyperglycemia, the cardiorenal metabolic axis. So the floor is yours, Dr. Osama.
Bismillah ar-Rahman ar-Rahim. Thank you, Prof. Ibtisam, for this kind invitation for me. Anyhow, our topic today is about beyond hyperglycemia, cardiorenal metabolic axis. It's really now becoming one of the most important subjects to discuss with it. Next, please. Ladies and gentlemen, just for a short definition of type 2 diabetes, I endorsed it to Royal College of Physicians in 2019. I said that type 2 diabetes is a chronic, catabolic, progressive hyperglycemia status. This is common, all of you know about it. But what's really about pathogenesis, it's insulin resistance and beta cell dysfunction that lead to micro and macro complications. The Royal College wants for me to give one line about the management. I say avoid hypoglycemia and avoid weight gain. And simply, if you avoid hypoglycemia and weight gain, you will have now the point what we call it cardiorenal axis protection. Next, please. Just to see what's going on in our area in 2000 and up to 2026, we see that cardiovascular renal really have a very big burden. If you look carefully about renal, there's more than 850 million. They have chronic kidney disease that represent 11%. And if you look about diabetes, more than 530 million people, they have really diabetes, and the numbers exceed more and more. And our region is particularly very high in the prevalence and incidence of type 2 diabetes. It may be up to 15% in the Gulf area. And if you look about heart failure, which is really very important, and cardiovascular disease, it's around 60%. Next, please. The point that it's not only this burden, but it's really we call it mixed, it's a vicious circle. Once you will have diabetes, you are prone to have chronic kidney disease. Once you have diabetes, you are prone to have atherosclerotic cardiovascular disease, heart failure, and the combination is really exceeds up to 14% of people with type 2 diabetes. They have chronic kidney disease. Up to 16% of people with heart failure, they have already type 2 and chronic kidney disease. And up to 20 to 40% of people with heart failure, they have really type 2 diabetes. For that, it's not only to say only diabetes or only heart failure or only chronic kidney. It is a mixed area, vicious area that contribute that all of them can be happen in one subject per se. And this is really very common. And the recent area being published in Lancet, they confirmed that diabetic people, they have more than 30% heart disease, they have more than 40% chronic kidney disease, and 38% they have heart failure. And this is really utmost important that we can discuss it this night. Next, please. Really, I selected the American Diabetic Association standards, and this has been published in 2016, 2026. Let us see what's going on about this interesting, the ADA 2026. At the next. Look carefully about the two columns, one previous focus and now 2026 strategic shift. What was really the difference between the two previous focus? We were focusing on A1C reduction, aiming for kidney. as a microalbuminuria. But in 2026, the American Diabetic Association changed it completely. They say that A1C reduction. A1C reduction does not mean only like this, and really organ protection. This word organ protection was not there in any guideline. Before it was A1C reduction, now organ protection, particularly for cardiovascular diseases. And what they meant and what they emphasized about the prioritizing GLT2 and GLP1 for cardio-renal benefit independent of A1C. Whether your A1C is 12, A1C is 9, A1C is 8, A1C is 7, independent, you need what you call it to organ protection. And this is now the hallmark of 2026, that if you are aiming for reduction in A1C, you are aiming for cardiovascular protection, you are aiming for kidney protection, and you are aiming for heart protection, and all of this combined now the new recent guideline for 2026. Before we had an active treatment of complications. Now, no, it is proactive comprehensive screening. You need to screen for bone, you need to screen for liver, and you need to see for psychological access. And this is really hot important thing. Before the patient comes to us, ignoring his psychological status, and just we give him medicine on like this. At that point before, we were using manual glucose meter, particularly for glucometer, now being changed completely to glucose continuous monitoring, which is really very important to have an automated glucose management. Before we were pushing for a general health lifestyle advice. Now it's personalized. Osama is not like Ibtisam, not like Muhammad, not like others. And this is what we call it integrating social determinants of healthcare. And this is really now the major difference between the previous and between the recent one, 2016. But please pay attention that A1C reduction, but with it, organ protection. Next, please. What's really again important about American Diabetic Association 2026 that albuminuria is not a kidney marker only. It is a marker for everything. It's a systemic marker, and they put it as a red flag. Pay attention to it. It's not only kidney, but a systemic marker, red flag marker, which is really utmost important thing. We need to screening is very important, particularly for urine albumin creatinine ratio, and this is now the standard for every diabetic patient. Treat the patient and not A1C reduction. And this is again for our people, family medicine, dentist, whatever. We need to treat patient and not at A1C. Don't aim for reduction of A1C. It is one of the good things, but look carefully for your patient and watch for the red flag, particularly the red flag, particularly for urea albumin creatinine ratio, and particularly what we call it estimated GFR. Now, the two criteria for now management of type 2 diabetes is estimated GFR plus urine albumin creatinine ratio. Next, please. And this is really an algorithm that's being published in American Diabetic Association 2026. What's really the aim? First of all, first step for management of type 2 diabetes is a screening, which is really the initial thing. Then the action for treatment, what you are aiming for. You have kidneys, you have heart, and you have other cardio-renal metabolic syndromes. First of all, if we put diabetes as a criteria, but we need to put what are really the risk factors. Particularly if you have insulin resistance for obesity, insulin resistance for hypertension, insulin resistance for type 2, heart failure, and the chronic kidney disease. Look carefully about the treatment. They put on the top as either for obesity, GLP-1 for reduction weight, but look for hypertension, ACE inhibitor. Look for type 2 diabetes. The two things, either you put GLP-1 or GLT2. Look for heart failure. Now it's becoming a treatment for heart failure even without diabetes. Look for chronic kidney disease. Again, it's one of the management of chronic kidney disease, LG2, and now recent standards for kidney treatment is to start GLP-2 even without any diabetes or diabetic or impaired glucose tolerance test. And this is what the bottom line, what they are looking for urine albumin creatinine ratio, try to cut it from macroalbuminuria more than 300 to macroalbuminuria, and you need to repeat it to see whether the benefit should be more than 30% reduction of urine albumin creatinine ratio. Look carefully about decline in the function, which is really very important, particularly for chronic kidney disease. And again, look carefully for your heart, for your kidney. And at best modality, as I said, SGLT2 could be the best modalities. If you look in the bottom of the right side, you will find that GLT2 is now the best treatment being emphasized by American Diabetic Association 2026. Next, please. And this is being reviewed by and put as a standard for American Diabetic Association. And already they reviewed more than 432 randomized control studies. They showed it was really the endpoint that SGLT2 and GLP-1 reduce risk of peripheral artery disease, kidney outcome, weight reduction, and HbA1c. Look, this is a very simple message to us that the GLP-2 now could be the best modality besides the GLP-1 if patient is obese, that aiming for peripheral artery disease, is aiming for reduction of kidney outcomes, reduction of weight, and HbA1c at the end of the study. With no increase in cancer risk. Some people come to my clinic, oh, I'm afraid that SGLT2 may cause for me cancer. Other part says that it will deteriorate kidney or deteriorate heart. We should really become myths that been published from TikTok or from WhatsApp or from all this media, and we should need really to avoid our patients from such false things about recent like GLP2 and the GLP1. Next, please. If HbA1c remains high and used, for example, metformin or water modality, what's really now become the combination of GLP1 and GLT2 could be the best modality for treatment of type 2 diabetes, particularly if the patient is obese and he can benefit from GLP1. If patient has a problem kidney, problem heart, and problem atherosclerosis or heart failure, one of the best modalities is really SGLT2 modality. And second point, that heart failure in both kinds, that first line is SGLT2. Imagine that the patient comes to me with heart failure without diabetes. The first line is really SGLT2. And the GLP1 if glycemic uncontrolled and weight reduction is aimed or needed. This is really very simple sequence for the management of type 2 diabetes according to American Diabetic Standards 2026. Next, please. And again, in American Diabetic Association 2026, what they recommend, and this I emphasized before, that targeting at least 30% or more for reduction of urine albumin creatinine ratio. Don't re-screen for urine albumin without following up. Following up is more important to see if there is a significant reduction, significant benefit by using GLT2 for kidney or for heart and for heart failure. This reduction strongly predicts the slower chronic kidney disease progression and is achieved best with either by ACE inhibitor, GLT2, or GLP1 if there is beneficial effect for reduction of weight. Next, please. As I started from this simple presentation, that we need to look beyond hyperglycemia, cardio-renal metabolic axis. What's really, if I now explain the American Diabetic Association 2026, what's really my aim? Is it only guidelines? No, it's not only guidelines. We need how to interpret it and how we to implement it, and according to them, HbA1c reduction plus organ protection. And this is really our aim as doctors. We need to look for organ protection, and perhaps a reduction in HbA1c, and management of cardio-renal and metabolic axis. Next, please. This being published in 2022 by New England Journal of Medicine. What's really important that cardiovascular disease can occur even before diagnosis of type 2. Once patients come to the clinic with diagnosis, just being diagnosed as type 2, you need to tell them that they have really diabetes even before heart disease. More important than that, development of microvascular complications is really occur or happen before the 3 years of diagnosis. Imagine like microalbuminuria, neuropathy, nephropathy, they may be started before the 3 years of the diagnosis, which is really unbelievable. I cannot say that diabetes type 2, no. There is microalbuminuria, there is nephropathy, there is neuropathy, even before diagnosis, at least before 3 years. And even development of a atherosclerotic process can occur even before 10 years of diagnosis. And risk factor for cardiovascular disease, like hypertension, like obesity, insulin resistance, can occur even before 15 years of diagnosis. And this is our issue, how to tackle really diabetes. Diabetes, as I said, is not a number, it's not a figure. It is really how to can I reduce micro and macro complications of diabetes. Next, please. Next. Please go before one. And next, yeah, this one. This is a very interesting study being published around 2022 to see the parallel of type 2 diabetes and patients without diabetes. Look about the parallel two lines as if they are the same from 1990 up to 2012 or 2014. The same morbidity mortality occurred for type 2 diabetes compared to the without diabetes. Look about mortality, they didn't change. Why? Because simply we didn't touch diabetes as a patient for cardiovascular, patient for hypertension, patient for kidney disease, and peripheral artery disease. For that, it's mandated now to go on, let's see what's going on. Next, please. People, they, before, let me say, for 2016, were looking only at HbA1c as a marker for diabetes. And this is really a false marker for measurement of type 2 diabetes. Let us see why. Next. And this has been published in American Diabetic Association 2026. Don't look only for HbA1c. Look, but for the recent cardiovascular outcomes either from Europe or from America, to put it and implement it as a management for type 2 diabetes, avoiding only to look for HbA1c. Next, please. And if we look carefully about the last 10 years, all of the endocrinologists, cardiologists, nephrologists, family medicine, primary care physicians, they were thinking about how such a lab for SGLT2 that will happen. And I published this one in JAMA in 2021. Why now change the whole area of medicine by using SGLT2? Why such a lab being using for SGLT2 as a main management for type 2 diabetes? Next, please. First of all, let us put in our mind, and this is a first message that I want to endorse this night, that reducing the risk of premature cardiovascular diseases and kidney disease is therefore now a management priority for type 2 diabetes. It's not management priority for HbA1c, but we need to look to risk of premature cardiovascular and kidney disease as top priority for management of type 2 diabetes. Next, please. And I think some of our ladies physicians, they attend what you call it the ADA in Stockholm in 2016. And in that meeting, they have two sessions about using anti-hyperglycemic agent and cardiovascular disease. And this is really because at that time become very hot area, and even for the Empagliflozin study. But look carefully to what's going on. We have really four major important randomized control trials: the UKPD study, the ACCORD study, and ADVANCE study, and VEDET study. If you look carefully, you see what's going on in all of these studies, the major important studies for type 2 diabetes. There was a reduction of microvascular diseases, but there was no reduction in macrovascular diseases. And even in ACCORD study, there was an increase of cardiovascular disease. From this study, all of physicians be aware and astonished. We're using treatment reduction of HbA1c, and there is no reduction of cardiovascular disease. And these are now, if you are, for example, to be examined for MRCP, one of the questions about UKPD study, latest one, and one question will be used about ACCORD study, ADVANCE study, and VEDET study. And from this, all of the physicians changed to go what's going on. In that meeting, the Stockholm meeting 2016, I attended, and patients be shocked that what's going on for management of type 2 diabetes. Next, please. And again, I put this one for World Health Organization in the region in 2019. I put really the main treatment for type 2 diabetes is microvascular reduction and macrovascular reduction. And in between, there is really what you call it heart failure. Next. And this is what we call it now the landmark of after cardiovascular disease outcome studies, which is really evidence-based approach. In 2015, I put these three columns: microvascular, macrovascular, and heart failure. Next, please. And before it, please. Yeah, this is what we call it balance. No, before. And this is being balancing glycemic control and adverse effects. Professor Inazusi in 2016, all that being published in Stockholm meeting 2016, that what he put for us a small schematic plan that the management is no hypoglycemia, no weight gain, achieve target of HbA1c and postprandial. Next. And that meeting also 2016, the Empagliflozin study being published. It was really a most important landmark study for type 2 diabetes, and it was the most important study that been endorsed in Stockholm meeting, the ESAD meeting, and the ADA meeting in 2016. What is this study tell us? What's going on about the new area of management of type 2 diabetes? Next. And this has been published in a New England Journal of Medicine 2016-2015. What is the deal? The empagliflozin, cardiovascular outcome, and mortality in type 2 diabetes. And before they gave us the results, there was a question from the presenter saying that, what do you think about the reduction of cardiovascular disease in Empagliflozin study? Some people say 5%, some people say 10%, 15%. And the shock comes out what's going on. It was really the top agenda in Stockholm in 2015 and the ADA 2016. Let us see the results of this important landmark study. There was the major adverse coronary artery events reduction of 13%. Imagine simple using of like empagliflozin. Cardiovascular disease reduction in outcome up to 38%. Reduction of heart failure and hospitalization up to 35%. And worsening of nephropathy up to 39%, and all cause of mortality up to 32%. And there were a lot of cardiologists attending this session, and the question was, is there any medicine in cardiology that can reduce such a definite reduction in all of cardiovascular, nephropathy, neuropathy, heart failure? The answer was not. But abusing simple medicine like empagliflozin can make something change, miracle, that there is really a significant reduction. This study is a very randomized control study, evidence-based study telling us what's going on. Next, please. And let us narrate some of the studies for empagliflozin to see that now SGLT2, particularly empagliflozin, can help your patient, protect your patient. Take this word, protect the patient. Early screening, diagnosis, and intervention of SGLT2 can change your whole life. Holistic management is required for people with chronic kidney disease, heart failure, of type 2 diabetes, and cardiovascular with renal and metabolic. Established a very safe profile. There is minimal adverse effect, well tolerated, and convenient once daily or twice daily, whatever you want. And this is now what we call it international chronic kidney disease, heart failure, type 2 disease guidelines recommend the use of SGLT2, in particular empagliflozin, as early foundation therapy for type 2 diabetes, even without type 2 diabetes, for cardiology, for heart failure, and chronic kidney disease. Next, please. And again, let us narrate more about the effect of cardiovascular disease, kidney function, as initial statement or initial use that slower empagliflozin. Look carefully about the significant reduction from all patients with estimated GFR. There was increased benefit for GFR by empagliflozin outreach study. And this is really, again, one of the landmark studies. And due to its hemodynamic mechanism of action, now empagliflozin caused an initial reduction in estimated GFR. And this now can be used of safety, even if GFR above 30, but not below 30 or 25. Next, please. And let me summon what's going on for this simple presentation. I hope you can get some benefit from it. That empagliflozin provides a triple protection by reducing risk of broad range. For example, you have type 2 diabetes, cardiovascular, 38 up to 32%, heart failure, 25, its two kinds, 25 up to 21, and chronic kidney disease up to 28%. It's a magic medicine for kidney, magic medicine for heart failure, and magic medicine for cardiovascular disease. In addition, empagliflozin provides metabolic benefit of type 2, including reduction HbA1c, systolic blood pressure, and what do you want more than that? If we took the model of Onizusi, the American diabetic president, 2016, he said that the main management of type 2 diabetes, no hypoglycemia, reduction of weight, and hoping for HbA1c and postprandial indices. Next, please. And let me summon to see what's, because kidney now is becoming a more advanced management in order to stop patients to go for dialysis and other things. We need to stop it as early as possible. And there was really significant reduction by more than 28% in kidney disease progression, more than 13% in the rate of all causes of hospitalization. Imagine that simple medicine can reduce hospitalization process, which is really now very important for us to look carefully. Now, what's going on for the recent data that comes from all recent guidelines, that empagliflozin can be used with or without type 2 diabetes, mildly to severe reduction in estimated GFR, up to more than 20%, and with and without cardiovascular disease, diabetes without cardiovascular without type 2 diabetes. Next, please. And if you look carefully for all guidelines, even up to ADA 2026, and for ADA 2023, the ESAD and ADA 2023, and kidney disease 2022 guidelines, ADA kidney disease, etc. All of them emphasize on one simple medicine. The simple medicine really now used is really SGLT2 as the best modality, first-line treatment for type 2 with chronic kidney disease. And regarding the SGLT2 inhibitors are recommended as a first-line therapy for people for type 2 diabetes and chronic kidney disease. Next, please. Let me end up to what's going on now. Empagliflozin provides protection. Please pay attention to this word, protection. People with heart failure across the recent study at the EF spectrum by reducing the risk of cardiovascular disease, death, and heart failure, up 25% compared to 20%. Consistent efficacy across the subgroups with or without type 2 diabetes, with or without chronic kidney disease. And this is now really the utmost important thing. Next, please. Let us see that in empagliflozin, it's really one of the best modalities. There is a very minimal or no significant hypoglycemia, even if you add it to metformin. Metformin was the cornerstone for management of type 2 diabetes. Now, combination of metformin with empagliflozin, one tablet, one single dose, can really benefit the patient much without thinking about significant hypoglycemia. Next, please. Ladies and gentlemen, I endorsed this for Royal College of Physicians in 2023, and after cardiovascular outcome studies from 2015 up to 2020, even now, the ADA 2026, what's really aiming for now medicine is not, for example, Osama Khatib or Muhammad or whatever. Now it is really what is called integrating evidence and practice medicine. Next, please. And as I said, this has been published for Royal College of Physicians and endorsed in 2026 by American Diabetic Association. What's really next, please? What's it done before? Really, the management is to avoid weight gain and hypoglycemia, avoid macroalbuminuria as a marker for systemic disease, not only a marker for renal disease. Cardiorenal protection, very important. GLT2, GLT1 could be the best modality. Why? Improving quality of patient's life, no hypoglycemia, and no weight gain. And this summarizes the whole medicine that will be for this night. Next, please. Let us give us a summary of what's going on. That there is now scientific evidence and the clinical evidence indicate now a GLT2 inhibitor, like one of them, empagliflozin, provides benefit across cardio-renal metabolic disease. Now, this is now most access for cardio-renal protection. Global clinical guidelines, recommending all of the guidelines, including the latest one, American Diabetic Association, for patients with type 2 and cardiovascular, and type 2 without heart failure or kidney. The best one could come from empagliflozin, and implementation of an evidence-based medicine guideline. Utmost important, it is a holistic approach to care provides appropriately for reduction in cardiovascular, kidney, and metabolic complications for type 2 diabetes. And even this one being included now in American Diabetic Association, that is one of the best modalities for protection of an organ like a kidney, other, and the more important for screening now as early as possible, even for diagnosis of type 2 diabetes. Next, please. And this had been a question been asked in 2000, I think, if I'm not wrong, 22, by American Diabetic Association. There was a lot of endocrinologists at that time, and that area, but it's like GLT2 was shy to start on it. And the question was really, if a patient with heart failure, what's really the best approach of patient with heart failure with diabetes? The answer was SGLT2. A patient had chronic kidney disease, albuminuria, preferably SGLT2 inhibitors. The best modality And GLP-1, the proven cardiovascular benefit is GLP-2 inhibitors not tolerated well. And for atherosclerotic cardiovascular disease, the best modality either to have GLP-1 for reduction of weight, GLP-2 for organ protection. So this is really in 2022. That was the question for endocrinology, and I think now the question for us as a family medicine, endocrinologist, internist, and primary care that try to think about that SGLT2 could be the best modality for organ protection to heart, kidney, cardio-renal, and metabolic axis. Next, please. I want to summarize. I start by this, I will end up by this. That the previous focus, we were focusing on A1C reduction. Now A1C reduction plus organ protection. And they put an arrow for cardiac, that one for kidney. Now reactive treatment of complication, now proactive treatment for complication. Manual glucose, now we have glucose monitoring continuously. And as I said before, it was generalized lifestyle advice, now integrating social determinants of health, what you call it SDOH. Next, please. Ladies and gentlemen, time for adoption of SGLT2 in clinical practice for kidney cardiovascular reduction among type 2 diabetes. This is being published by JAMA November 2025, and the same wording, but changing some wording, even by American Diabetic Association. Next, please. Thank you very much. Always think about cardio-renal and metabolic axis. Next. And thank you very much.
Thank you very much, Dr. Osama, for the nice presentation highlighting on this important disease. And as we know that type 2 diabetes in the past used to be called metabolic syndrome, and this terminology have changed over the past few years as you have highlighted, from metabolic syndrome to metabolic, cardiac, renal, and more recently hepatic syndrome. So diabetes is not anymore one specialty disease. It requires multidisciplinary care, and we are lucky to have also development in pharmacotherapy, as you have mentioned, to address different pathophysiology that can be used not only by endocrinologists, but also by cardiologists, nephrologists, hepatologists, to address the risks and complication, and also to reduce the morbidity and mortality. So with that, we can open the floor now for discussion and question. If you have any question, please post it in the chat area. So Dr. Osama will get ready for answering those questions. So anyone have any question, you can raise your hand or put your question in the chat box.
My pleasure to answer.
Do we have any question? Up till now, we don't have any question. So it means most likely that Dr. Osama, you have addressed everything very clearly. Mr. Hatem, do you see any questions? I don't see any questions yet. Yes.
لا دكتور
There is one question here. I can see one question now. People started putting question. The question is, what dose of empagliflozin do you recommend to use? Dose in regards to empagliflozin.
This is really a very important question. We have 10 milligrams, we have 25 milligrams. And even in combination, we have 5 and 850 metformin, or 10, 850 metformin, or 12.5, 850 metformin. If you have an elderly patient, try to start in a small dose and increase it by time. But the most important thing, don't get scared. Even 12.5 milligram of empagliflozin is very important for reduction, cardiovascular, for heart failure, and even for kidney disease. Now, before it was using empagliflozin below 30, now it is up more than 20. And to that, it's a really very safe medicine. There is minimal risk factors, particularly for UTI, or particularly among ladies. But this is can be treated simply by one tablet, and that's it. For that, start, for example, by 10 milligrams. If you want to use to add metformin with it, for example, 10, 850, 10, 1,000, or even 12.5, 850, 12.5, 1,000.
So just in summary, you can use the lowest dose like 10 or 12.5, you will get the cardiovascular benefit. And you need to
Absolutely.
increase the dose, yeah. If you need more glycemic control, then you can double the dose, but you need to have a good or acceptable EGFR to get the glycemic benefit. But for cardiovascular benefit, we don't need to increase the dose. I think the smaller dose will do the benefit. Is that
And the
right?
important thing that if you apply to American Diabetic Association, that don't look for a figure, look for the urine alveolar creatinine ratio. Your aim is to reduce it by 30% at least. And don't, for example, check it once yearly. No, check it in a cyclical 4 months and see the reduction of urine alveolar creatinine ratio. Besides the estimated GFR, these two things are now utmost important target access for organ protection.
Absolutely. So we give it not only for glycemic, but we give for cardio and renal, even for people without diabetes, right? So the smaller dose,
Even now the cardiologist is using it more than endocrinology.
Yep.
And nephrology is using even more than endocrinology. But the aim of this small session or small important that we really need to change the medicine for type 2 diabetes. But now we have to protect the organ, heart, kidney, and cardiovascular diseases, aiming for reduction in the prevalence or incidence of cardiovascular and nephropathy.
Yeah. So the aim
And
now,
as you said,
yeah, not like in the past.
Yeah. Go ahead.
Yeah, I mean, I'm just highlighting what you are saying. It's not like in the past we are treating complication. We are giving medication to prevent the progression of complication. So,
yeah. And the word they use it for American Diabetic,
protection. Yes.
It's really very nice, simple, and really means a lot. Protect organ, heart, protect kidney, protect heart failure.
Okay, there is one more
and
question.
Also now, the reason, as you said, protect liver. There's a cardiorenal liver.
Yeah, so now there's a lot of talk about steatosis, or what we call it NASH or MASH, metabolic associated liver disease. There is two more questions. One question is, can we start with the highest dose of Synjardy immediately?
If you have young patients with risk factor, now you can start 12.5 or 12.5 BD or 25, make it next step or third step. But don't start aggressively. You will get benefit for cardiovascular even as Professor Kisham said by small dose of Empagliflozin.
Okay, so the idea here is, as you mentioned, we increase if we want more glycemic control. So you can start with the smaller for the cardio protection and then increase if glycemic control is required. And this is what the drug recommendations also does. So the other question is, can you give us a family medicine, can you give us as family medicine doctor good guidance to apply in our clinic for DM patient care using this type of meds? And what about pregnant lady or young patients with obesity? So they want guidance, in primary care.
And pregnancy contraindicated absolutely, period. Regarding using it in young type 1, there are now 3 small studies telling that you can use it with type 1 if they are overweight or obese. But again, still it is a small 3 studies, but till now the recommendation from ADA not used as a standard of work. But for type 2, go ahead. But there is what you call it mature onset of young diabetes. With obesity, feel free to use it because the main cause for MODY or LADA or whatever it is in young, that you need to protect them from atherosclerotic process. Because atherosclerosis occur more commonly than type 2 diabetes. For that, you need to protect if they are obese and they have, because I always use this from Professor Stephen Bloom, that all type 1 diabetes will end up as type 2 diabetes. And all of type 2 diabetes can end up of diabetes type 1. Type 2 end up by using insulin at the end, and type 1 will end up because they are becoming insulin resistant, using more insulin. And for that, if patient is obese, above age of 15, you can use either GLP-1 or GLP-2.
So, I mean, using it in young patient with obesity, I think this part need to be splitted. I mean, if we are talking about young patient with obesity without diabetes and not at risk of cardiovascular or renal, then probably this drug is not approved for obesity, right? But if the patient is with diabetes,
GLP-1 is approved.
Yeah.
GLP-1
No, but if
for them
yeah,
is approved
but
for
the
obesity
GLP-1
and young.
Yes, exactly. GLP-1, some of them can be used even at age of children above 18, yes. Yeah.
Even 12 now.
12,
The
yes. But
recommendation but for
absolutely.
GLT2, the patient is obese. Sorry, in Saudi Arabia, we have a lot of people with multi-type or ladder type or what you call it type 2 diabetes, or even type 1.5. These people, if they are not insulin dependent, or even I've seen around 40 cases from South Hospital that they are obese type 2, type 1, tend to be type 2, all of them. And this is the question. If they are type 2, without even afraid, with not insulin, can use freely either GLP2 or GLP1.
Yeah. So just to simplify
because
it,
now, because in France now they endorse 35 types of MODI in France, and I think now we have here a lot of patients being diagnosed as type 1 tend to be type 2.
Yeah.
Particularly young.
Yeah. Just only to simplify it, maybe we can say that if you have a patient, young patient or adult patients with obesity without diabetes, then the drug of choice will be GLP-1 receptor agonist if there is no contraindication. But if you have a patient without diabetes, but he is at risk or having cardiovascular or renal disease, probably you can use the SGL2 inhibitor or even GLP-1 receptor agonist if they're obese. But if they are diabetic, the first question you need to ask, do they have cardiovascular disease or at risk of cardiovascular disease or renal disease? Then the choice will be for GLP-1, SGL2 receptor plus metformin. And if they are obese also, then you can select the GLP-1 receptor agonist. Maybe this is just only a simple way. And I think American Association have highlighted on this. Yes, Dr. Osama? Yeah, do you want to add? Yeah. So this would be the easiest way for a family physician. I mean, first question you have to ask the patient. They have diabetes, they have cardiovascular, they have renal disease, they have even NASH, because now the ADA have added a column for metabolic associated liver disease. So if they have NASH, then also you may select, I mean, there are drugs shown improvement of NASH with using them like GLP-1 receptor agonist and SGL2 inhibitor, some of the SGL2 inhibitor as well. Yeah? Any more questions? Any more comments from Dr. Osama?
Thank you very much, Professor.
So if there are no more questions, then I would like to thank you very much, Dr. Osama. Thank also Boehringer for opening the floor for discussion and inviting us for discussing this important topic. And just I leave the floor for Hatem if he wants to add anything. Thank you very much for the audience to stay in.
Thank you. Thank you for the audience. Thank you, Dr. Osama. Thank you, Dr. Sam, for your attendance today. Many thanks for your efforts.
Thank you very much, all of you. Take care, and we'll see you soon.
Bye-bye.
See you soon.
Okay. مع السلامة.
مع السلامة. السلام عليكم.